Optic disc swelling. This is Professor Maha Shahin, Mansoura University. Examination of the retina, including a good detailed examination of the optic disc and retinal blood vessels, offers a wide window on the brain. Optic disc swelling is a common and an important sign associated with a group of diseases. On the top of them is papilledema, associated with raised intracranial tension. Papilledema should be differentiated from pseudopapilledema. What is pseudopapilledema? It's a group of disc pathologies that give the optic disc an appearance similar to a swollen disc. The one that carries the most resemblance to disc swelling is drusen of the optic disc. Others are tilted disc, crowded hypermetropic disc, and peripapillary myelinated nerve fibers. Inflammation of the optic disc, that's say papillitis, is presented by red swollen disc. Other inflammatory conditions of the eye, such as uveitis and posterior scleritis, are associated with disc swelling. The second most common optic neuropathy is anterior ischemic optic neuropathy. It is presented as white papilledemic disc. Other occlusive disease, such as central retinal vein occlusion, is sometimes associated with disc edema. Congenital labor hereditary optic neuropathy may be associated with disc edema. It's crucial to identify drusen of the optic disc. Drusen of the optic disc is seen in about 2% of the general population. They are bilateral most of the time. Patients with drusen of the optic disc is asymptomatic. However, some of these patients may complain of transient blurring of vision due to ischemic changes caused by the crowded disc. The clinical picture is similar to a case of papilledema. Patient with transient blurring of vision. On examination, there is good visual acuity and bilateral apparent disc swelling. During childhood, the drusen are under the surface of the optic disc, giving the disc lumpy appearance. Then, drusen come to the surface of the optic disc and they appear purely white in color. They increase in size with the passage of years. Some cases with drusen of the optic disc are complicated by juxtapapillary choroidal neovascularization. It's important to differentiate between papilledema and drusen of the optic disc. Absent cup, anomalous vascular appearance, for example, increased number of major blood vessels, proximal branching, and tortuosity are in favor of drusen. On the other hand, congestive signs such as hyperemia and vessel obstruction are in favor of papilledema. Drusen of the optic disc are autofluorescent. What is autofluorescence? It is the ability of the structure to absorb light in a certain wavelength, namely the blue wavelength, and reflect it in another wavelength, namely the green wavelength. How to look for this autofluorescence? Get your patient to the fundus camera, introduce both the barrier and exciter filters, and then look at the optic disc. You can see the typical hyperfluorescence caused by the drusen. They appear without injection of the dye. There is no dye. This is autofluorescence. Calcified drusen will produce highly reflective foci by ultrasound. Papilledema. Papilledema is a very common condition. What is papilledema? Papilledema is optic disc swelling due to raised intracranial pressure. All patients with papilledema should be investigated for the presence of intracranial mass. However, not all patients with raised intracranial pressure will develop optic disc swelling. What causes papilledema? On the top of the causes are idiopathic intracranial hypertension. The most serious is space-occupying intracranial tumor. Obstruction of the ventricular system is another cause of raised intracranial pressure. Or impairment of CSF absorption, as in cases of meningitis, cerebral venous sinus thrombosis, and cerebral edema from blunt head trauma. Normal intracranial pressure is typically less than 250 millimeter water when measured in the recumbent position. What are the symptoms of papilledema? Patients with papilledema complain of headache, nausea, and to less extent from visual symptoms. Headache characteristically is in the morning. It awakens the patient from sleep. However, it still can occur in other times of the day. It increases with bending of the head, as in praying. It may be localized or diffuse. Papilledema is associated with nausea, sometimes projectile vomiting. In some patients, nausea may precede headache. In the early stages of papilledema, patient will have no visual symptom. With the progress of the papilledema, patient will complain of transient blurring of vision lasting for about 30 seconds, either in one or in both eyes. Patient may complain of diplopia due to stretch of one or both abducent nerve. This is a false localizing sign. Visual acuity is good till the late stages of papilledema when post-papilledemic atrophy develop. Once you diagnose a case of papilledema, patient should be referred for neurological examination and investigation. Sometimes diagnosis of mild edema is tricky. Spontaneous venous pulsations of the retinal veins are helpful in that issue. It's absent normally in about 20% of the general population, and sometimes it's hard to detect. However, it has been shown since 1878 that spontaneous venous pulsations occur only in patients with CSF pressure below 180 mm water. Thus, the presence of spontaneous venous pulsations indicate that this disc is not swollen at this particular time. Not all patients with raised intracranial pressure will develop disc swelling. And those who developed post-papilledemic optic atrophy will have little or no edema, even with the continuing increased intracranial pressure, as there are no fibers to swell. So, the absence of disc swelling does not exclude the high CSF pressure. Papilledema is bilateral disease. However, it may be asymmetric, as we can see in this patient. In mild cases of papilledema, there is mild hyperemia and mild blurring of the disc margin. If spontaneous venous pulsations were previously seen in this patient, it is lost. If spontaneous venous pulsation is detected in either eye, this means the CSF pressure is within normal limits at this time. With the progress of the disease, the papilledema is established with marked hyperemia, with peripapillary flame-shaped hemorrhage and sometimes cotton wool spots. Some patients may have circumferential retinal folds. Macular fan is seen in young patients. What is macular fan? It's radiating lines of exudate from the macula to the optic disc. In chronic papilledema, there is good visual acuity, but the visual field starts to constrict. Hemorrhage and cotton wool spot disappear, and opticociliary shunt may appear. Finally, the patient passes to the post-papilledemic optic atrophy. The optic disc appears pale with moth-eaten appearance, and there is marked loss of vision. Idiopathic intracranial hypertension was previously called pseudotumor cerebri or benign increased intracranial tension. The typical profile of this patient is middle-aged, obese female. They present with a typical picture of papilledema. So, other causes of papilledema should be excluded before a diagnosis of idiopathic intracranial hypertension is made. It's a disease of exclusion. Patient is treated through losing weight. Treatment is by acetazolamide and digoxin. Sometimes lumpectomy shunting is needed, or optic nerve fenestration. Intravenous mannitol or lumpal puncture is usually done for cases with high level of CSF. The use of steroids is controversial. Anterior ischemic optic neuropathy is either arthritic or non-arthritic. Arthritic is caused by giant cell arthritis. What is giant cell arthritis? It's inflammation of the large and medium-sized arteries. Its other name is temporal arthritis due to inflammation involving the superficial temporal artery. The disease is more common in females above the age of 50. It is associated with scalp tenderness due to inflammation of the superficial temporal artery, jaw claudication, headache, and pain in the proximal muscles in the shoulder and the arm. The disease is both life and sight-threatening one. Examining the superficial temporal artery is a good diagnostic tool. The artery is thickened, inflamed, and tender in cases of giant cell arteritis. Absent pulsation of the superficial temporal artery is highly suggestive of the disease. ESR is very high, and in cases of equivocal ESR results, raised C-reactive protein is diagnostic. Temporal artery biopsy is highly recommended in cases of suspicious of giant cell arteritis. However, do not wait for the result of the pathology to start your steroid treatment. Start with steroid treatment, and within 3 days you can get your biopsy. The biopsy should include at least 2 to 5 centimeters of the artery, as the inflammatory process may skip part of the artery. The treatment is oral steroids in cases where the optic nerve is not involved. Arthritic anterior ischemic optic neuropathy occurs in about 30 to 50% of patients with giant cell arteritis. The common presentation is sudden, marked diminution of vision in one eye. In about 1/3 of cases, the other eye is affected after 1 week. The vision is markedly dropped, and if both eyes are affected, the patient may end in blindness. The optic disc is characteristically white papilledemic one. The treatment should start immediately. Treat with intravenous methylprednisolone. The treatment may be accompanied by the use of aspirin. Unfortunately, the prognosis is very poor and the visual loss is usually permanent. However, early administration of steroids may lead to partial recovery of the vision. Non-arthritic anterior ischemic optic neuropathy is more common. It is the most common form of ischemic optic neuropathy and the second most common optic neuropathy after glaucoma. Non-arthritic anterior ischemic optic neuropathy is caused by short posterior ciliary artery occlusion. Predisposing factors are crowding at the optic disc with very small or even absent cup, which is called disc at risk. Hypertension is very common predisposing factor for non-arthritic anterior ischemic optic neuropathy. Diabetes, collagen vascular disorder, sudden hypotension are among the risk factors. The typical clinical presentation is sudden, unilateral, painless diminution of vision. This chromatopsia is usually proportional to the loss of vision in cases of non-arthritic anterior ischemic optic neuropathy, contrary to cases of papillitis. The typical field effect is altitudinal field effect. And I'm quoting from the patient will say, I can see half of the face. Investigating the predisposing risk factor is very important in this patient. The disc is swollen. Sometimes there is peripapillary splinter hemorrhage. Fluorescein angiography shows early defective filling of the disc capillaries, then localized hyperfluorescence and diffuse hyperfluorescence in the late stage. Differential diagnosis of non-arthritic anterior ischemic optic neuropathy include papillitis. Non-arthritic anterior ischemic optic neuropathy is usually seen in patients over 50, while papillitis is usually seen in patients under 40. Non-arthritic anterior ischemic optic neuropathy is painless, but papillitis is associated with pain, especially on movement of the eye. On examination of the visual field, non-arthritic anterior ischemic optic neuropathy shows altitudinal field effect, while papillitis shows central field effect. The optic disc is pale in cases of ischemic optic neuropathy and is hyperemic in cases of papillitis. Peripapillary hemorrhage is seen in cases of ischemic optic neuropathy, while it is absent in cases of papillitis. This chromatopsia is proportional to the visual loss in cases of non-arthritic anterior ischemic optic neuropathy, while it is markedly affected out of proportion to the degree of vision impairment in case of papillitis. The prognosis of non-arthritic anterior ischemic optic neuropathy is much better than the arthritic one. About 50% of the patient will regain their visual acuity. However, recurrence and affection of the other eye may occur in some patients. To date, there is no definite treatment of non-arthritic anterior ischemic optic neuropathy. Control of the systemic risk factors is important. Some authors are in favor of use of short-term steroid therapy for better chance of improvement. Aspirin was not found to reduce the risk of involvement of the other eye, and optic disc fenestration has not shown to be beneficial. Posterior ischemic optic neuropathy is much less common than the anterior one. It does not produce optic disc swelling. Early in the disease, the optic disc is normal, and then it becomes atrophic over weeks. It's a disease of exclusion. Other causes of retrobulbar neuropathy should be excluded. For example, compression or inflammation. The most common cause is perioperative, usually due to anemia or hypotension. Unfortunately, it is bilateral. Other causes are the same as anterior ischemic optic neuropathy. Diabetic papillopathy is postulated to be an uncommon variant of anterior ischemic optic neuropathy. However, it occurs in younger diabetics. It may be bilateral, and in cases of bilateral diabetic papillopathy, papilledema due to increased intracranial tension should be excluded. The disc is hyperemic with multiple telangiectatic capillaries on the surface. These telangiectatic capillaries may be mistaken for new vascularization. The prognosis is very good. Labor hereditary optic neuropathy leads to degeneration of the ganglion cell. It's caused by maternal mitochondrial inheritance. The typical presentation is male in his third decade complaining of sudden, painless, unilateral loss of vision. Then the other eye follows after weeks or months. On examination, the optic disc is swollen, hyperemic, with dilated capillaries over the disc and extend to the adjacent retina, that's to say, telangiectatic microangiopathy. There is also swelling of the peripapillary nerve fiber layer, and then there is optic atrophy. And despite the optic atrophy, the pupillary light reaction appears relatively good. What's next? Multiple research groups have studied retinal nerve fiber layer in neurological disorder such as MS, Alzheimer, Parkinson's disease, and schizophrenia. Changes seen in retinal layers offer diagnostic and sometimes prognostic clues to this disease. Thank you.